Welcome, everyone. Today we're taking a closer look at rectal cancer management, but maybe shifting the focus a bit from the initial diagnosis and planning.
That's right. We're diving into what happens during and crucially after treatment. Things like managing those tough on-treatment toxicities, figuring out the best follow-up plan, and really supporting our patients in their survivorship journey.
Exactly, because, we spend so much time on the technical stuff, staging, anatomy, neoadjuvant approaches, planning the radiation fields.
Absolutely essential groundwork.
But our job doesn't end when the treatment machine switches off, does it? Managing the patient's whole experience, that's a huge part of what we do.
It really is. To make this concrete, let's think about a patient. Say, Ms. Chen. She's 42, just finished long-course chemoradiation for a T3N1 tumor, part of a TNT protocol.
Okay, so she's been through a lot already.
Definitely. And now, in these last few weeks of radiation, she's really struggling. Significant skin irritation, pretty bad diarrhea, and she's anxious.
Understandably. What's she worried about?
She's asking those key questions. What happens after my surgery? How are you going to watch me? Will you know if it comes back? And what's life going to be like after all this?
Yeah, those are the questions, aren't they? And they perfectly frame our discussion today. It really highlights how our role goes way beyond just delivering those grays.
Absolutely. It's about guiding her and patients like her through everything that follows. So let's start with those acute side effects. Pelvic radiation, especially with chemo, it causes issues.
No doubt. Proactive management and just good patient education seem critical here.
They're absolutely crucial. It helps patients get through treatment, improves compliance. It really matters.
So let's tackle some specifics. Anal and rectal pain, tenesmus, that awful feeling of needing to go constantly. What are we seeing and what are the practical tips?
Yeah, those are very common. Patients describe a sharp or burning pain. And that tenesmus is just incredibly frustrating for them. Like they can never fully empty their bowels.
So what can we actually do about the pain?
A really effective practical thing is topical lidocaine ointment. We usually tell patients to mix it 1-to-1 with something like Desitin or Aquaphor.
Okay, 1-to-1.
Yep, and apply it right to the anal canal and the surrounding skin, as needed for relief. It can make a big difference.
That sounds like a great clinical pearl. Simple, but effective. What about the tenesmus itself, that feeling of urgency?
Well, the tenesmus, while really uncomfortable, often tends to peak maybe a week or so after short course RT finishes, and then it usually resolves on its own.
Ah, okay. So it gets better.
It generally does. So a big part of managing that is actually just patient education and reassurance, letting them know what to expect, that it's likely temporary.
Setting expectations. Okay. Let's move to another big one.
Okay.
Diarrhea. Almost universal, right?
Oh, absolutely. Diarrhea is something nearly everyone experiences to some degree. The first step is always dietary changes, recommending a low-fiber, low-residue diet.
Right. Reduce the load on the bowel.
Exactly. Then, pharmacologically, loperamide is the go-to first-line agent. We tell patients to titrate it based on their symptoms, how frequent the stools are.
And what if that's not enough? Say, Miss Chen is taking, I don't know, 8, 10 loperamide tablets a day and still having major issues.
Yeah, if you're getting up to needing more than 8 loperamide tablets a day, that's significant. The next step, pharmacologically, would be to consider difenox late at ropine Lomatil.
Okay, Lomatil.
But here's a really critical point. If the diarrhea is severe, like grade 3, and refractory to these measures, you need to talk to medical oncology about potentially holding or reducing the dose of the concurrent chemotherapy, like epecidopine.
Before stopping radiation.
Absolutely, before considering a radiation therapy treatment break. Radiation dose intensity is just so critical for local control in rectal cancer. We really want to protect that radiation schedule, if at all possible. Talk to MedOnX first.
That's such an important clinical decision point. Protect the RT dose. Anything else in the toolkit for really stubborn diarrhea?
For very severe refractory cases, yeah, there are other options like tincture of opium or sometimes anti-motility agents like dicyclomine or hyoscyamine might be considered, but those are usually further down the line.
Got it. Okay, how about skin reactions? Perineal dermatitis can be really miserable for patients.
It really can, especially in that area. It can range from just some redness, erythema, all the way to moist desquamation.
Oof, moist desquamation sounds rough, where the skin actually breaks down.
Exactly. It's weepy, painful, and definitely increases the risk of infection.
So how do we manage that? Cleaning, healing, what works best?
Sitz baths are fantastic. Just warm water, sometimes with a little dilute hit of cleanse added, helps soothe and clean the area.
Right.
We also encourage frequent showers or tub baths, just gentle cleansing.
And topicals, does it differ for dry versus moist desquamation?
It does. For dry desquamation, simple emollients usually do the trick, things like Aquaphor or A&D ointment to keep the skin moisturized and protected. For moist desquamation, you need something more. Dressings like Aquacel Silver can be helpful because they're absorbent and have antimicrobial properties. Or sometimes a mix, like 1-to-1 zinc oxide and bacitracin, can create a good barrier.
Zinc oxide and bacitracin, okay.
And sometimes, if there's sloughing skin, you might need to do some gentle debridement with tweezers, just carefully removing the dead tissue to allow for healing underneath.
Right, get rid of the barrier to healing.
Precisely. And look, if it's really severe, not healing, seems infected, don't hesitate to get a dermatology-oncology consult. They can be incredibly helpful.
Good point. Okay, last acute toxicity area, urinary symptoms, burning, frequency. What's the approach?
Yeah, dysuria and frequency are pretty common too. First thing always is rule out a UPI. Get a urine screen and culture right away.
Standard procedure.
Yep. If the culture's negative, then it's likely radiation cystitis. For symptomatic relief, phenazopyridine is a common brand name. Works well for the burning.
Ah, the one that turns urine orange.
That's the one. You absolutely have to warn patients about the orange urine or they'll get quite a shock.
Definitely. Anything else for urinary issues?
For male patients specifically, if they're having trouble with urination, like hesitancy or retention, tamsulosin or Flomax, can often help relax the bladder neck and improve flow.
Okay, great practical tips for getting patients through treatment. Now let's shift gears. Treatment's done. Ms. Chen has had her surgery. What's next? Surveillance and survivorship. This seems like where the path really diverges depending on treatment, right?
It absolutely does. Post-treatment surveillance looks very different if the patient had surgery, like a TME, versus if they pursued a non-operative management or watch-and-wait approach after a clinical complete response. The NCCN guidelines are our main guide here.
So let's start with the more common scenario, probably surveillance after surgery, after TME, assuming no known residual disease, like for Ms. Chen. What do the NCCN guidelines, REC10, I think you mentioned, recommend?
That's right, REC10. For these patients, it involves several components. First, a history and physical exam, H&P, every 3 to 6 months for the first 2 years.
Okay, pretty frequent early on.
Yes. Then it goes to every 6 months for a total of 5 years. Same frequency for the carcinoembryonic antigen, the CEA blood test, every 3 to 6 months for 2 years, then every 6 months up to year 5.
Why that intensity early on?
Because the highest risk of recurrence, particularly distant metastatic recurrence,
Yeah.
is within those first 2 to 3 years. So you're watching most closely then.
Makes sense. What about imaging?
Imaging is typically a CT scan of the chest, abdomen, and pelvis. The recommended frequency is every 6 to 12 months for a total of 5 years.
6 to 12 months, so maybe annually, maybe twice a year, depending on risk factors.
Exactly. It allows for some physician discretion based on the individual patient's risk profile.
And colonoscopy. Crucial for local surveillance, I imagine.
Very crucial. The recommendation is a colonoscopy 1 year after surgery. If that's normal, the next one is in 3 years, and then every 5 years thereafter.
What if they find something on that 1-year scope, like an advanced adenoma?
Good question. If an advanced adenoma is found, you'd repeat the colonoscopy in 1 year. And another key point, if the preoperative colonoscopy wasn't complete, maybe because the tumor was blocking the scope,
Right, happens sometimes.
then you need to ensure a complete colonoscopy is done within 3 to 6 months after the surgery.
Okay, that covers the bases. Just to be crystal clear, PET scans, are they part of routine surveillance after surgery?
No, not routinely. The NCCN guidelines don't recommend routine PECT for surveillance outside of a clinical trial. It's usually reserved for problem solving, like if the CEA is rising but CTs are negative, or for initial staging but not standard follow-up.
Got it. Now let's flip to the other path, non-operative management, or watch and wait. This is for patients who achieve that clinical complete response, CCR, after neoadjuvant therapy. You said the surveillance is much more intense. Why?
It is definitely more intensive. The rationale, based on the international consensus recommendations from 2021, is that you've left the rectum in place. So while you're watching for distant meth, like in the post-op setting, you have the added critical task of watching very closely for any local regrowth at the original tumor site.
So what does that entail? HMT and CEA the same?
Yes, HMP and CEA follow a similar schedule, every 3 to 6 months for 2 years, then every 6 months for a total of 5 years.
But the local surveillance must be different.
Radically different. This is where the intensity ramps up. Digital rectal exam, the DRE, and either proctoscopy or flexible sigmoidoscopy, actually looking inside the rectum, are recommended every 3 to 4 months for the first 2 years.
Wow, every 3 to 4 months.
Yes, very frequent. Then if things remain stable, it can be spaced out to every 6 months for a total of 5 years. This frequent endoscopic evaluation is absolutely key to catching local regrowth early when it's potentially salvageable with surgery.
And imaging for watch and wait. Is it just CTs?
No, there's more. A rectal MRI is recommended every 6 months for up to 3 years. The MRI is particularly good at looking for subtle changes or early regrowth in the rectal wall at the treated site.
Okay, MRI every 6 months for 3 years. And CTs.
CTs of the chest and abdomen are still done, similar frequency to post-op. Every 6 to 12 months for 5 years, looking for distant disease. The guidelines also suggest including a pelvic CT once you stop doing the routine rectal MRIs.
I see. And colonoscopy.
Colonoscopy schedule is similar to post-TME, recommended 1 year after finishing therapy, and then frequency depends on the findings, usually every 3 to 5 years if normal.
That is a lot to keep track of, especially those first couple of years for watch and wait. Any tricks to remember it?
Yeah, it's definitely complex. A little memory aid I use is the intensive 2. Think of those first 2 years as the intensive 2 period.
Intensive too, I like it.
During those first 2 years, you're doing the DRE, the scope, and the MRI frequently, like every 3 to 6 months. That's your hypervigilant phase. After year 2, if everything looks good and stable, you can start spacing things out a bit, maybe to every 6 or 12 months.
The intensive too. That's helpful. It really highlights where the focus needs to be. What's the biggest challenge with keeping patients on that demanding schedule?
I think compliance can be tough. It's a lot of appointments, invasive procedures. It really comes down to communication, explaining why it's so intensive, reminding them that this close surveillance is the trade-off for potentially avoiding major surgery. Empowering them with the rationale helps.
Makes sense. Okay, we've covered acute issues and surveillance. Let's move into the really long-term view. Survivorship. Beyond just monitoring for recurrence, what are the key aspects of supporting patients like Ms. Chen for years down the road?
Survivorship care is incredibly important, and it's gaining more focus, thankfully. It's about managing long-term side effects, monitor from recurrence, yes, but also promoting overall health and quality of life.
So what are the big pillars of survivorship care after rectal cancer treatment?
One huge area is pelvic health and sexual function. Treatment, especially radiation, can have significant long-term impacts here. We strongly recommend pelvic health physical therapy, PT, for essentially all patients, male and female.
For everyone, why is it so beneficial?
Yes, for everyone. Pelvic health PT can make a massive difference with things like chronic bowel dysfunction, including low anterior resection syndrome, or LARS, which is a collection of bowel symptoms after surgery.
Right, urgency, frequency, incontinence.
Exactly. PT also helps with sexual dysfunction, both male and female, and chronic pelvic pain. It's often underutilized, but can be truly transformative for quality of life.
That's a really important point. What about specifics for female patients like Mrs. Chen? Vaginal health after radiation.
Absolutely critical. For women, vaginal dilator use is essential to prevent or treat vaginal stenosis. That's the narrowing and shortening of the vagina from radiation scar tissue.
Which can make intercourse painful or impossible.
Precisely. Patients need education on this. They should ideally start using dilators about 4 weeks after finishing radiation, maybe for 5 to 10 minutes 3 times a week.
And then for how long?
For at least 12 months. But ideally, it should be ongoing, lifelong maintenance for many women to preserve function. It takes commitment.
Commitment, but worth it for quality of life. You mentioned dose earlier.
Yes, there's data, for instance, from MD Anderson back in 2023 showing a pretty clear correlation. Higher radiation doses to the anterior vaginal wall, specifically a D 50% greater than about 48 gray, were linked to worse sexual dysfunction.
Wow, so our planning really matters there. Every gray counts.
It really does. And beyond dilators, we need to proactively discuss sexual health. Ask about potential issues like erectile dysfunction in men or dyspareunia, painful intercourse, and vaginal dryness in women.
Don't wait for them to bring it up.
Definitely not. Many patients are hesitant. Bringing it up, normalizing the conversation, and offering resources or referrals to specialists like gynecologists or sex therapists is part of comprehensive care.
Okay, pelvic health is key. What else falls under long-term survivorship?
Bone health is another important one, often overlooked. Pelvic radiation can weaken the bones in the pelvis, increasing the risk of insufficiency fractures.
Fractures not from a fall, but just from weakened bone.
Exactly. Stress fractures in the sacrum or pubic rami are the common ones, so we need to counsel patients on bone health.
What do you recommend?
Adequate calcium and vitamin D intake is fundamental. Aim for about 1,000 to 1,200 milligrams of calcium per day and 800 to 1,000 IUs of vitamin D daily, mostly through diet and supplements if needed.
And any specific screening?
Yes, especially for postmenopausal women, we should encourage them to get DEXA scans with their primary care doctor to screen for osteoporosis. Catching it early allows for treatment to strengthen bones.
Good advice. Now, a really sensitive topic, especially for younger patients like Miss Chen at 42, fertility.
Hugely important, and the timing of this discussion is critical. It has to happen before treatment starts. Pelvic radiation can cause premature ovarian failure, leading to infertility and early menopause.
So what can be done?
For premenopausal women who desire future fertility, ovarian transposition is a key procedure to discuss.
What does that involve?
It's a surgical procedure, often done laparoscopically, where the surgeon physically moves the ovaries out of the expected high-dose radiation field.
Where do they move them?
Typically, they're tacked up superiorly, often into the paracolic gutters, alongside the colon, high up in the abdomen. This drastically reduces the radiation dose they receive.
Thereby preserving ovarian function and fertility, potentially.
Exactly. It's not guaranteed, but it significantly increases the chances. Referrals to reproductive endocrinology before any treatment starts are absolutely essential for these patients.
That really underscores the need for multidisciplinary coordination right from the beginning. For Ms. Chen, unfortunately, that ship might have sailed if the discussion didn't happen pre-treatment.
It highlights a potential gap we need to be vigilant about closing. It should be part of the initial consultation for any premenopausal woman facing pelvic radiation.
Okay, last big area of survivorship. Lifestyle. What are the key modifications we should be emphasizing?
Some fundamental health behaviors make a big difference. Smoking cessation is paramount. Huge impact on overall health and cancer outcomes.
Non-negotiable.
Pretty much.
Yeah.
Alcohol should be consumed sparingly, if at all, and physical activity is incredibly important.
How much activity are we talking about?
Even just brisk walking for at least 30 minutes on most days of the week can have significant benefits. There's strong evidence supporting exercise.
You mentioned evidence. Wasn't there a trial, the challenge trial maybe, looking at exercise in colon cancer survivors?
Yes, exactly. The challenge trial, published in the New England Journal of Medicine, I believe in 2025, it showed that a structured exercise program significantly improved outcomes for colon cancer survivors.
What were the numbers again? They were quite striking.
They were. It showed an improvement in 5-year disease-free survival, 80% in the exercise group versus 74% in the control group, and also better 8-year overall survival, 90% versus 83%.
That's really compelling. It's not just about feeling better, it actually impacts survival.
It really underscores the therapeutic value of exercise. Beyond that, diet matters too. Emphasize a plant-based diet, reducing red meat intake, and maintaining a healthy body weight. These are all things patients can control.
It gives them agency in their own health.
Exactly. You know, I sometimes think of survivorship care like the comprehensive support an athlete gets after a major competition. The treatment was the main event, the win. But the follow-up care, rehab, nutrition monitoring ensures their long-term health and ability to keep performing well in life.
That's a great analogy. It's about sustained well-being, not just crossing the finish line of treatment. Okay, this field is always changing. Any quick thoughts on major controversies or trials coming down the pike that might change practice?
Definitely a few things to watch. There's the ACO/ARO/AIO-18 trial, NCT number 042466884.
What's that one looking at?
It's a big phase 2/3 trial comparing long course versus short course radiation, but both arms get extensive consolidation chemo and have a really prolonged time before surgery, like 22 to 24 weeks. Could really change how we sequence TNT.
Interesting. Anything on re-irradiation for recurrence? Always a tough scenario.
Yeah, the ARO retry study, NTT 05481757, is looking specifically at that, a prospective observational study on re-irradiation for locally recurrent rectal cancer. We need more data in that space.
Absolutely. And metastatic disease.
There are several trials like GRECAR-8, CHIRO4, CLIMAT. They're exploring systemic therapy with or without upfront resection of the primary tumor in patients who present with synchronous unresectable METs, challenging the old dogma that you always have to take out the primary.
Fascinating. Lots to keep an eye on. Okay, let's transition to our board blitz segment. Quick questions, high-yield answers. Perfect for consolidating knowledge. Ready?
Let's do it.
Question 1. Acute diarrhea during pelvic radiation. What's the initial management strategy?
Start with a low-residue diet and loperamide. And crucially, only consider holding concurrent chemo, like capecitabine, after discussing with medical oncology and before holding radiation therapy, especially for severe refractory cases.
Perfect. Question 2. Patient had a TME, no known residual disease. Outline the key components and timing of their NCCN post-op surveillance.
Okay, post-TME. H&P and CEA every 3 to 6 months for 2 years, then every 6 months to 5 years. CT chest, abdomen, pelvis every 6 to 12 months for 5 years. Colonoscopy at 1 year, then usually every 3 to 5 years if normal.
Excellent. Question 3. Now switch to watch and wait surveillance after a clinical complete response. What are the key differences that make it more intensive?
The intensity comes from local surveillance. DRE and proctoscopy, or flex-sig, every 3 to 4 months for 2 years, then every 6 months. Plus, rectal MRI every 6 months for up to 3 years. That close watch on the primary site is the main difference.
Great. Question 4. Ovarian transposition. What's the rationale and where are the ovaries typically moved?
Rationale is to preserve fertility and ovarian hormone function by moving the ovaries out of the high-dose pelvic RT field. They're typically relocated superiorly into the pericolic gutters.
Perfect. First. Question 5. Why is pelvic health PT so crucial as a survivorship recommendation for both men and women?
It's crucial for managing common long-term issues like bowel dysfunction, LARS, sexual dysfunction, and pelvic pain, significantly improving quality of life for both sexes.
And question 6. Bone health after pelvic radiation. Key recommendations to mitigate pelvic fracture risk.
Recommend adequate calcium, about 1,000 to 1,200 milligrams a day, and vitamin D, 800 to 1,000 IU per day. And strongly consider DXA scans for postmenopausal women to screen for osteoporosis.
Fantastic. That was a great rapid review. Now let's apply this knowledge in a few clinical decision-making scenarios.
Okay, case time.
Case 1. A 35-year-old woman is about to start pelvic radiation for rectal cancer. She's very concerned about infertility. What intervention should be prioritized for discussion to mitigate this risk? Options are A. Hormone replacement during RT. B. Ovarian suppression with GnRH agonists. C. Ovarian transposition. Or D. Post-treatment egg retrieval.
Okay. Well, post-treatment egg retrieval might not be possible if the ovaries have failed. Hormone replacement during RT isn't standard for fertility preservation. Suppression might offer some protection, but the most definitive way to reduce ovarian dose is C, ovarian transposition.
C. Ovarian transposition. Final answer.
Yes, surgically moving the ovaries is the most effective strategy discussed here to minimize radiation dose and preserve function.
Excellent reasoning. Case 2. A 63-year-old man had a TME for T3N1 rectal cancer 6 months ago. He's starting routine surveillance per NCCN guidelines. What's the recommended frequency for his CEA test and his CT chest, abdomen, pelvis for the first 2 years? A. CEA annually, CT annually. B. CEA every 3 to 6 months, CT every 6 to 12 months. C. CEA every 6 months, CT annually. Or D, both CEA and CT every 3 months.
Okay, first 2 years post-TME surveillance. CEA is the more frequent one early on,
Yeah.
every 3 to 6 months. CT chest, abdomen, pelvis is every 6 to 12 months. That matches option B.
B, CEA every 3 to 6 months, CT every 6 to 12 months. You're confident.
Yes, that aligns with the NCCN RAC 10 guidelines for that initial intensive phase.
Correct. Final case, case 3. A patient on pelvic radiation with concurrent capecitabine develops severe grade 3 diarrhea. What's the most appropriate initial management strategy? A, immediately hold RT until symptoms resolve. B, discontinue capecitabine immediately. C, initiate aggressive antidiarrheals A&D, consider capecitabine dose modification with medical oncology. Or D, switch from capecitabine to infusional 5-FU.
Right, grade 3 diarrhea. Holding RT is the last resort. Discontinuing chemo immediately might be needed, but the first step involves optimizing supportive care and discussing the chemo with medical oncology. Switching chemo isn't the initial step either. So C seems most appropriate. Maximize the antidiarrheals and have that crucial conversation with med-onc about the capecitabine dose or schedule.
C it is. Great job working through those cases.
Hey there.
So just to quickly recap our discussion today, effective management of those on-treatment toxicities is just so vital. It helps patients tolerate treatment, stay on schedule, and get the full benefit.
Absolutely. And we saw how surveillance schedules are really tailored different paths for post-operative versus non-operative management, both focused on catching recurrence early. Precision matters there.
And finally, that comprehensive survivorship care addressing pelvic health, fertility, bone health, lifestyle. It's not an afterthought. It's absolutely critical for ensuring our patients have the best possible long-term quality of life.
It truly is about treating the whole person long after the radiation beams are off.
It really challenges us to think beyond the tumor, doesn't it? To be partners in our patients' long-term journey, something to reflect on. What aspect of this extended patient care, toxicity management, surveillance, survivorship will you focus on strengthening in your practice this week?
We hope this session gave you some valuable insights and practical tools. For more resources, including complete practice oral boards, check out radoncsmartlearn.com.
And please subscribe so you don't miss our next session. Thanks so much for tuning in today.